Neurocognitive Disorders, Topic 4, Formulating a Diagnostic Approach to Cognitive Impairment. Dr. Sara Gleason, Department of Psychiatry and Human Behavior. In previous modules, we examined the DSM-5 criteria for the diagnoses of delirium, major neurocognitive disorder, and mild neurocognitive disorder. We examined the differences between delirium and the dementias or neurocognitive disorders. This chart is a reminder of some of the differences between, say, delirium and a dementia or neurocognitive disorder. These are the sorts of differences in presentation that we'll be looking for in our diagnostic approach. First off, we must take a history, talk to the patient, also gather information from knowledgeable friends and relatives. Talk to the ambulance driver or other folks who were available at a scene if a patient was just brought into an emergency room. Look at the medical history. This may be available in an electronic medical record, or it may take more investigation. But medical history, both of general medical status and of any significant illnesses, will be key to your differential. Medications. Take a look to see what the patient is prescribed. Are they adherent to prescribed medications? Are they perhaps using or misusing medications due to their cognitive impairment? Check out the prescription monitoring program to get information about any controlled prescriptions. Ask about premorbid cognitive functioning and educational level. This will give you some idea about changes that have occurred from the time of a patient's younger years and also more recently. Family history is also important. Is there a family history of dementia? Is there a family history of any genetic illnesses that may lead to cognitive impairment? Substance use history is also very important. Has this person been a smoker for many, many years? Have they been a heavy user of alcohol? Is there a history of illicit substance use or perhaps misuse of prescription medications? For the psychiatric exam, we perform the mental status exam. We may rely on brief cognitive screening tools, including the mini mental state examination or the Montreal Cognitive Assessment. Other neuropsychological testing may also be appropriate and valuable. We may not always be able to access more elaborate neuropsychological testing batteries due to availability of experts, insurance coverage, and so forth. But when appropriate, do refer your patients to neuropsychological testing. Perform thorough physical and neurological exams. If there are any areas that would require expert exam and you are in a facility where you have consultants, ask for that expert level of examination. Brain imaging, whether it be CT or MRI or other sorts of tests, is very important. Make sure that you order the right kind of test for the questions that you're asking. Consult with radiologists or other specialists so that you don't inadvertently order an expensive examination that is not the right test for your patient. The mental status exam allows us to investigate alertness, orientation, behavior, memory, concentration, speech and language, abstraction, judgment, and insight. It's important to document these in the chart so we can compare how an examination may change over time. The brief screening tools that were previously mentioned include the Montreal Cognitive Assessment, MoCA, or the Mini Mental State Examination. Here, the authors of your osmosis module have written Mini Mental Status Examination. That's a common error that's made, but in fact it is actually the Mini Mental State Examination for the proper name of the test. At any rate, the MoCA or the MMSE will examine orientation, registration, recall, attention, and language. Here's an image of the mini mental state examination. And here is the MoCA. During your third-year rotation on the psychiatry or neurology services, you should have opportunity to use one or more of these screening tools. Labs. No workup for cognitive impairment would be complete without your basic labs like a CBC, a comprehensive metabolic panel, urinalysis, B12, folate, RPR for syphilis screening, HIV screening, TSH. There may be other labs that also are relevant depending upon your patient's medical history. Should you get genetic testing? Well, that will depend upon the workup to date and whether your workup points in the direction of a potential genetic disorder. It is important to get appropriate genetic counseling from specialists before pursuing genetic testing. Interventions. Family education is very important. We have to consider safety issues like driving or handling firearms in a patient who has cognitive impairment. We have to consider a possibility of in-home supervision. Will the patient need skilled nursing care now or down the line? Maybe assisted living would be an appropriate intervention. Power of attorney and financial decisions also come into play. Caregiver support is also essential. Caregivers can suffer from burnout. It is challenging, even in a time-limited situation, to be a caregiver for someone with cognitive impairment. But for those who play that role year in and year out, it is very, very challenging. In terms of support, the Alzheimer's Association website is shown here is one resource. There are other organizations that are disease-specific that can help with patients with dementia or other disorders.